Right. We're moving now to an in a much related, really, presentation, which is again in the same territory of the ERAS, and is now for Dr. Haytham Gameel, and he's Dr. Haytham is a cardiothoracic anesthetist in consultant in Aberdeen, United Kingdom, and he also is going to teach us now and give us some.
Can I?
That's fine. Dr. Haytham, he's going to enrich us again with about now about Dr. Haytham about the ERAS in cardiac surgery. It's one of the topics which is we have now a lot of ERAS is coming on
Yeah,
different areas, and I think also in our hospital we have the ERAS in obstetrics. There is a ERAS in of course for the orthopedic, colorectal. A lot of now they also going into a lot of other subspecialties, and this is one of the things which is I was expecting to hear from you, Dr. Haytham, today, and is about of the one of the areas which is in most,
yeah.
which is away from it, just a cardiac ERAS and cardiac surgery. So I'm 100% sure that you're going to give us a very fantastic lecture, and we'll get taught nicely tonight. Thank you very much, Dr. Haytham. Over to you.
Oh, thank you very much, Dr. Muhammad. Actually, as you mentioned, it's an era, not an eras. So probably it become really started in many surgeries, and then currently we get a consensus actually to apply it in the cardiac surgery. However, let me start first with really with the say that I'm very delighted actually to join this group of eminent speakers under the very role moderation of Dr. Muhammad Mustafa. Dr. Muhammad, really, I enjoyed many of your lectures. Our participation in the communication skill course was really amazing, and was a very good really addition to my career as well. So thank you for everyone, ladies and gentlemen. I will start really with the ERAS, and I think definitely Dr. Professor Medhat Shaib actually make the things like much more easier for me as well, because he put the fundamentals, the basics of the ERAS that came up with the kind of evolution to be applied in as an era in the field of the cardiac surgery. Well, I will not go definitely with the definitions, because I think Dr. Medhat actually managed to speak about it really in a very, very nice, detailed way. But it's a protocol-based multidisciplinary design to improve the various outcomes. And definitely it covers the preoperative and the intraoperative and postoperative periods by forming a kind of a bundles that it will be applied on those kind of periods in order to achieve the preferable outcome at the end. However, recently it became one of the forefront in the cardiac surgery. It started actually with Fleming et al. When you think that is it possible, I mean, is it applicable to apply the ERAS as a form of a protocol that could be applied in the cardiac surgery for CABG and valve in particular. The protocol include the ERAS-based strategies, such as reducing the preoperative fasting, minimizing the long-acting opioids, as simple as that, and applying the early start of the enteral feeding for those patients who stays for more than 24 hours or maybe 48 hours in the ITU, and facilitates and encourages the early immobilization as well. However, there is no significant difference in the length of the stay, and that's what makes him really have some sort of being skeptical slightly about the getting a benefit from applying it to the cardiac surgery. However, there is some significant statistical difference in the decrease in some of the complication, including the infection and renal injury, or maybe MI, or maybe at the end the morbidity and the mortality or the development of death rate. You can see here that the ERAS here actually is having three main bundles. One for definitely for the preoperative covers the intraoperative and the postoperative. But I think you agree with me that the cardiac surgery actually going in a different way, heading off away from the simple protocol, because it's a complex surgery. It is a costly surgery that actually consuming huge resources. And most of those patients actually having plenty of the comorbidities that might really affect the outcome at the end. And definitely those patients have a different post-operative course. They will not really tend to goes directly on the day surgery basis. We know that most of them should go to the HDU or the ITU. I will not go definitely through the components of those bundles, because I think Dr. Medhat actually managed to speak in details about it. However, now before the 2019, when the ERAS Cardiac Society released the first consensus that reviewed and came out with a very good guidelines for the patients undergoing the cardiac surgery, and they refer it to be the enhanced recovery after the cardiac surgery. There are many challenges to implement this in the field of the cardiac surgery. However, the cardiac surgery care has always involved definitely the cooperation and the collaboration between the multidisciplinary team, that it might really helps at the end to reach this consensus and to facilitate the post-surgical recovery as well. The aims in the cardiac surgery, and all of us know very well that it's a costly and it's time consuming, it's effort consuming as well, is to decrease the hospital length of the stay as much as we can, decrease the complications, the readmission rates and costs. Maybe we can apply it in a simple way, just to get guidelines, just to reach a consensus that really know how to deal in a proper way with those patients who came with a comorbidities, complex surgeries, and finally getting a significant reduction in the resources. I tried to hide definitely to hide the name of the companies, but actually we can check here actually that it's a kind of a cost, but sometimes it's a ghost. Why it's similar like the ghost? Because actually it's hard to figure out the exact cost of the hospital stay, and it differs from let me say, from an insurance company to different agents to different health providers. So at the end, it varies from 9,800 up to 11,700 in general per stay. However, if you can get really a very clear way to measure it, you can't really be able to manage it effectively. This actually is as simple as that it might really varies between the $29 per minute for the low complexity surgery up to $80 per minute for the high complexity cases inside the theater or in the back, or even during the taking the patient from the theater back to the ITU or the ICU. The average cost actually per day varies from one country to another. In the United States, up to 5,200 almost, and the cheapest is in Spain with the $424, which is it's quite cheap actually. So when building the ERAS protocol has been referred by Nassi et al., the complication and the length of stay actually affects really significantly the cost of the stay. Definitely, we should consider that those patients goes directly to the ITU. It requires a huge resources, a huge efforts that actually varies between a patient to another, and definitely the cost actually getting much more significantly higher with the age group between 45 years old to 84. And this very well explained, because of actually the old age means that they have plenty of comorbidities. Those are the bundles actually for the application or for the maintenance of the ERAS and the cardiac surgery. I start with the preoperative consideration, which actually vary from the preoperative components, the intraoperative components, and the postoperative, and it slightly might really match might really be able to be merged easily with the ERAS in the non-cardiac surgery. However, there is a few modifications, let me say, the few changes, few components that might be added, and I'm gonna talk about it, especially with the preoperative. And as Professor Medhat mentioned, actually, it starts really so early, rather than keeping the patient really in the fast track to be recovered. It starts even from the preoperative period. I would say that three main components in the cardiac surgery. We should maintain what we call it the stop, optimize, and encourage. Stop what? Stop the alcohol, smoking, drugs actually with the possibility just to apply this component quite earlier, up to 1 month, for instance. Optimize the blood sugar and the fasting period, and encourage for good nutrition and education, and for patient and the patient involvement. Here, the infection and respiratory issues, especially, it might really cause a slower wound healing, and might really precipitate a kind of bleeding and metabolic dysfunction. And that's why those, let me say, hazardous beverage should be actually stopped a little bit early, up to 1 month before the surgery, in order to avoid those complications. Again, the hyperglycemia is a very common in the cardiac surgical patient. Most of them actually have a peripheral vascular disease because of, on top of the blood sugar problems, they are receiving insulin. However, how far we can just manage to apply this control, it differs from one protocol to another. However, we should maintain that that the hemoglobin A1C should be really maintained in a very reasonable level before the surgery. We should really take into our consideration as well as that the 25% of our cardiac patients actually have a higher HbA1c, and almost like 10% of them actually is actually undiagnosed with this diabetes, or be diagnosed really by accident whenever they being tested for the surgery. Maintaining the level of the blood sugar normal glycemic level, and avoiding the tight control definitely is really preferable in those patients. And this is actually goes in line with and very adherent to the normal ERAS protocol. Most efficiently here, we should use the insulin infusion. And whenever it's possible, probably you should keep the HbA1c just below 6.5%, and avoid the tight glucose control, because definitely it might really cause hypoglycemia, which is definitely should be treated immediately if being discovered. How we can optimize the fasting period for those patients? So again, we know from the beginning that it might really stay fasting for 2 or 4 hours at least above before the GA, before the starting the conduction of general anesthetics, should be really taken slightly cautiously, because some of them, as we mentioned, is diabetic. So probably the 2 to 4 hours, I think, if we can minimize even up to 2 hours, probably giving them a clear fluid definitely could be very, very tidy for them, actually, in terms of the satisfaction, their satisfaction. And there is no, by the way, there is no risk of having an aspiration during the procedure. The clear liquid loading could be given up to 2 hours before the surgery, and definitely this will help to reduce the insulin resistance. And what we need just to emphasize here, that the insulin resistance definitely affects the inotropic support, affects also the period of staying on the bypass, and might have a different consequences in the post-operative period as well. Encouraging the patient engagement, making sure that you have a very good functional capacity, it should be emphasized. And moreover, improving the patient engagement through his education, through very, very well significant, really, explanation for the whole process, definitely would really have a very good consequence into the post-operative period. Here, the nutrition should be um, maintained in a different way. Um, Actually, the guidelines supports really to maximize the nutritional status in the preoperative period. And definitely, this bundle should be started a bit earlier, 7 up to 10 days from the procedure. Definitely encouraging the patient as well to perform any kind of preoperative exercises associated definitely with the less preoperative insulin resistance, and definitely will affect even the hemodynamic stability as well, and make the condition much more neat and tidy. Okay, now, yeah, for going to the intraoperative consideration now, and the intraoperative consideration is a little bit slightly different, because here, compared to the ERAS, the normal ERAS protocol, or the cardiac ERAS protocol, we have the bypass. The patient who goes on bypass, the patient will have a huge wound in his sternum. Plenty of people actually provoking marvelous efforts in order to keep this patient safe at the end. Here, the most important surgical wound site of infection will be the sternal wound, definitely. And this should be actually taken in consideration whenever we try to control this infection. And about 1 to 4% of the cardiac surgeries might really have a kind of morbidity or mortality because of this wound actor. The main organism here is Staph aureus in most probably 30% of the cardiac patients. And that's why, according to their guidelines, we should encourage the intranasal Staph aureus therapy, and the different protocols based on the facility or based on the local protocols to apply the intraoperative antibiotics in order to avoid those infections. Here, we should maintain an anesthetist the use of the short-acting medication. For instance, using the remifentanil TCI. Remifentanil is a very good drug, short-acting drug that could be actually continued even in the post-operative period as well. The depth of anesthesia should be monitored with the use of BES or with the entropy. And moreover, the relying more on the short-acting drug like the dexamethasone now is being encouraged, but definitely not in the theater, mainly in the post-operative period in the ITU. Here, to consider the monitoring, which is really very important component of the maintenance of the adequate hemodynamic stability, we should encourage the use of goal-directed fluid therapy using the pulse contour analysis monitor, whatever it is, and there is no conflict of interest here. You have plenty of options, plenty of brands actually that might really helps you to retrieve a kind of a data about the cardiac index, about the MVO2 saturation, the urine, for instance, getting informations about the SVV, stroke volume variation or stroke volume index, getting informations about the SVR, the resistance or the pulmonary vascular resistance, the extravascular lung water. The main thing here actually is to tailor the use of your inotropes, your vasopressors, your volume, in order just to give the right thing to retrieve the adequate hemodynamic stability. The application of a new parameters like the hypotension predictive index, it might really helps along with the use of the SVV and the other parameters like the BBV and the other parameters, in order just to choose the right thing in order to maintain the hemodynamic stability with the least manipulation, with the using the inotropes or the vasopressors, and maintaining the eovolemia and at the same time adequate hemodynamic stability. And definitely this will help actually to initiate the early weaning of the inotropes and maintaining the hemodynamic stability. During the bypass, encourage your colleagues in the perfusion department or in your perfusion team to encourage the adequate cerebral protection, initiating or applying the cerebral protective strategies, maintaining cardiovascular protective strategies for aortic or for valvular or for the coronary surgeries, maintaining the renal protection. Try to limit the cross clamp time. The bypass, probably we need definitely a very fast and very well expert in the field, this field actually. And moreover, adequate blood transfusion if the hemoglobin is above 10 or 11, and that currently has been applied in many centers as well in many protocols. In case of you, if you are really concerned about the renal perfusion, probably the higher cardiopulmonary bypass flow might really imposed or maybe implemented in order just to maintain adequate renal perfusion. And we'll see this really later, just because it might really helps to prevent and to avoid the AKI. Here, the guidelines for the pain management actually is important, and it's slightly very close and very adherent also to the ERAS protocol in the non-cardiac surgery. Here, they encourage and they recommend as well the use of multimodal opioid sparing approach. How? Just try to use the opioid uh, if you can just apply the short-acting opioid if you need just to use the opioid as definitely as a considerable way to control the pain. Try to use adjuvants to lower the opioid requirements using the acetaminophen, gabapentin, which becomes more popular now, tramadol, which is very popular as well, using the dexmedetomidine, using the ketamine, lidocaine, magnesium, and some of the steroids as well for controlling the PONV or the nausea and vomiting as well, along with the use of those medications. Definitely compared to the normal ERAS, or let me say the usual ERAS in the non-cardiac surgery, we should avoid the use of non-SAIDs because have definitely a very bad consequences in terms of thromboembolic risks, and it should be avoided definitely in the cardiac surgery. The Here actually it's really a little bit controversial because I think it will be difficult actually to get a consensus with the surgeon that we can use the nerve blocks targeting the intercostal nerves that it actually fits the lateral and anterior chest walls. Currently becomes a little bit popular to apply the pectoralis nerve block or serratus anterior, or maybe erectrospiny single shot. Definitely avoid the catheters. There's no place to catheters. There's no room for the catheters here actually, because those patients, as we all know, receiving heparin for going on bypass and definitely reversal. However, avoiding if you're willing actually to give nerve blocks, you should avoid the transversus thoracic muscle brain block, because it might really damage the lima and rema, and the left internal mammary and the right internal mammary, and might lead actually to spillage of the local anesthetics to the mediastinal cavity. However, we still actually it's not widely applied in most of the centers now, because I think it might really find a kind of a resistance from the surgical team, because and this, if the patient develop any kind of hematoma, definitely they might really blame the nerve block for that. The maintaining the normothermia is one of the main targets here, and avoiding also the hyperthermia, or definitely we should actually the hyperthermia is not really deliberately occurs, but in case of you need to rewarm the patient, don't over rewarm him because it might really affects the cognitive dysfunction, might have a very big consequences on the infection and the healing as well. And definitely avoid the hypothermia, because it might really cause problems with the bleeding, might really precipitate infection, and definitely it might really increase the mortality and actually elongate the hospital stay as well. Here, we reach the guidelines from the Society of the Cardiovascular Anesthetists and about the use of the thromboelastography, TEG or ROTEM, in order to achieve actually the best management for the blood and blood product, and just tailor out your choices in order just to give FFP or platelet in case of the patient still really having problem with the bleeding or like dumping a lot of blood in the chest tube. here to avoid that as well. The guidelines really emphasize and recommend on using the IACA or as antifibrinolytic medications. The IACA means the epsilon aminocaproic acid, or the tranexamic, which is actually much more famous. And definitely this might really helps to reduce the blood products and limits the need of transfusion and over transfusion as well. I will reach the post-operative consideration, which is actually to be kept on our loop because to keep you away from the obstacles that might really prevent you from the reach or to achieve the adequate recovery for your patient. It starts really mainly in the post-operative period. For instance, the prolonged ventilation. So you should have a protective lung strategy, hemodynamic stability, and you should really apply monitors. AKI should be considered. The bleeding and the possibility of having a blood replacement plan should be taken into consideration as well. If the patient having a delirium BOCD definitely will stay for ages in your ITU, and finally the Dvt protection as well. Let me start first with the protective lung strategy, and as simple as been mentioned, you can just apply whatever you think that is safe for your patients. However, try to minimize the mechanical ventilation, initiates the protocol that helps actually to encourage the early extubation up to 6 hours after the ICU admission. It could be as safe if the patient definitely have a very good blood gases, and we should consider that the patient safety is first. So it's not really running. We are not really running after the ERAS, or ERAS in the cardiac surgery, and at the same time neglecting or ignoring the patient safety. However, if the patient is fine, have a very good ABG, and you apply the protective lung strategy from the beginning, you can actually go for the extubation, and this definitely will limit his stay and definitely will have a very good consequences on his recovery. AKI, the acute kidney injury is very common and definitely is very costly in terms of this long length of the stay in the hospital as well, or in the HDU or in the ITU in general. We have currently they came up with a kind of a urinary biomarkers that might really helps to predict and facilitate the risk stratification and definitely the early intervention of the AKI. My advice actually to involve the nephrology team. They might have, rather than giving like furosemide and or Lasix or giving spironolactone for the patient with heart failure, probably the involvement of the nephrology team definitely will actually make a very, very significant difference, because you might really need to start the filter or the CRRT as early as possible. Definitely during the bypass time as well, you might really encourage your crew and the perfusion team to start the ultrafiltration, or encouraging them in some particular situations to apply a higher bypass flow to provide a renal perfusion strategy. Here, the delirium is very common, especially with the elderly patients, and most of the elderly patients have a cardiac problem, and most of them are really wheeled directly to the cardiac surgery. However, it's up to 50% in some of the studies. And apart from that, it might really had a very significant really impact on the cognitive recovery of our patients, and might really precipitate very bad consequences as well in terms of staying in the hospital. Definitely, we should consider that the long-acting medication, whether it's sedatives, opioids, and anxiolytics, might really definitely have a very bad impact in the development of this delirium and the cognitive dysfunction. Therefore, you should consider that the delirium should be monitored very regularly, and to be attacked and be counteracted, to have a very good approach in order to control it as early as possible. One of the main bundles actually should be applied with those patients is the non-pharmacological treatment. Try to avoid the pharmacological treatment or the chemical treatment as much as you can. Like simply, you can change the sceneries, encourage the family visits, and the involvement of the patients with a very nice and very friendly talk. Educate the family about the possibility of development of this and then the behavioral changes and other things. Put them in a quiet room with a low lighting. Let them have a very good sleep, because the main problem with most of our ITU and most of our really, let me say, our healthcare providers, or let me say our nurses, they are doing their best actually to help the patient. They are doing the washing for the patient, doing grooming, doing the patient care, and that might really having a problem about the disturbance, with the disturbance of the sleep rhythm, and it ends after 2 or maybe 4 days to develop this kind of delirium or a confusion. And encourage, by the way, encourage, don't, if you can, don't ignore that the patient might have a problem in his ears. So give him the hearing aids or his glasses so he can see and really listen clearly. Here, you should maintain a very close observation for the preoperative anemia. Avoid the anemia. Preoperative nausea and vomiting should be really treated, and you should have a prophylaxis to avoid it as early as possible as well. The early post-operative enteral feeding might really advised and many emphasized in many protocols as well. The early physical rehabilitation is required. Try to, if it's safe, I mean, try to remove the chest drain if it is within the protocol as soon as possible. Try to sit the patient, mobilize him to the chair as soon as possible, if it's safe, definitely, with the aid of our really gorgeous physiotherapists. The aim mainly is to avoid the development of the DVT and the pulmonary embolism, which should be preventable actually in the cardiac surgery, and relying on the mechanical thromboprophylaxis using the below knee socks or the pumps or sitting on the chair. Definitely much more advisable and much more really profitable in terms of compared, and might really outweigh the use of the chemical thromboprophylaxis. However, if you need it, you can start it from the day 1 of the surgery, especially with the valvular heart surgery as well. Here, the chest tube, we should involve really the cardiac surgical assistants or the cardiac surgical team as well, to avoid the clogging, which is really fairly common with the cardiac surgery and may lead to the pericardial effusion, definitely a critical hemothoraxes. It might really end with AF and hemodynamic stability and start really to run for further re-exploration in the wounds as well. The unclogging, usual milking, it might really provided using the smaller tube. And the suction definitely is one of the main maneuvers to avoid it. And if you can apply the new chest tubes, might available in one of the centers as well, many centers as well, it might really have similar, which have a very advanced clearing or advanced suction methods that might helps actually to avoid any clogging of the tube as well. I'm reaching the conclusion, and by the way, I believe that when we talk about the ERAS or the ERAS, that's actually what I believe. It should be it definitely should be detailed, and at the same time should be very fast as well, because its time is of essence, definitely, and time is important with that. But at the same time, the details actually should be emphasizing on the patient safety. So we are not really trying to facilitate the patient recovery, kick him out of the ITU, send him, escalate him to the HDU or to the ward in order just to clear the bed for another patient. No, it's not about the cost, it's not about the time. It's mainly about the patient's safety. And because we know that the application of the ERAS or the ERAX will help with the patient ability to recover as soon as possible. That's why we should know from the beginning that it's complicated and yet promising target for the enhanced recovery. And although that those kind of challenges might really, let me say, overcome the need of the application of this protocol in a very particular way in many interventions. However, it's mainly standardized to be applied since the preoperative period, during the intraoperative, and finally in the postoperative period as well, in the form of the protocols that it might really be crucial and should be implemented to achieve the ERAS protocol in the cardiac surgery. The guidelines, definitely, which been, I think it's been modified and been altered for several times. It might really helps actually to provide a very, very good vehicle in order to achieve this target at the end. We should consider as well that the impact of having a COVID definitely had a very bad impact on most of our physician, nurses, allied health workers, the need of ventilators, the ICU beds, the capacity of our ICUs, the changing of the ICU from one place to another in order to accommodate more COVID patients, the cost of application of nutrition and TBN and all BBE as well for our patient. However, this also, it will never be an obstacle against the application of the ERAS protocol in the cardiac surgery. Simply, this is the bundles and the preoperative and intraoperative and postoperative. It's very simple, actually. It's very so simple to retrieve. It's very simple, actually, to scroll it. And thank you very much. And thank you for all my dear speakers. Actually, it starts with a huge, let me say, achievement with how to treat the heart failure, how we can apply the ERAS in the non-cardiac surgery. And finally, thank you very much for allowing me to discuss the ERAS in the cardiac surgery. Thank you very much.
Thank you very much, Dr. Haytham. It's really, really fantastic, spot on. It's really interesting. It's really interesting to see how it's such right a really important ERAS programs being spread out to take most of the subspecialties and things like you saying, Dr. Haytham, like the cardiac surgery. It's really difficult, and I personally I never thought about some of the areas like the cardiac surgery and cardio-thoracic and how we can nicely get involved with the expediting the patient recovery and improving their ambulation and their pain management. And as you mentioned, with ERAS, it's really it's the same standard way, like Professor Medhat mentioned. It's the same way, but how is artistically you are using this in a special way in your area of subspecialty, in orthopedic, in cesareans, and also obstetrics, in cardiac surgery, in vascular. It's really important. Dr. Haytham, just a simple question for me. What are you using for regional anesthesia for as a part of the ERAS in your center?
Well, to be honest, we don't use the regional anesthetics at all. I'm not saying that actually it's been resistible. I mean, but let me say that let me just take you slightly away from the cardiac surgery. For instance, I believe that even the thoracic surgery, even as well, it's not actually very familiar. Not all of the people are familiar to apply the ERAS protocol in the thoracic surgery. But
it is applied.
Yeah, currently, I was saying currently it's been applied. I mean, initially it was difficult actually to be applied. Nobody knows how can we send the patient, I mean, away from the HDU while the patient having a huge thoracotomy wound, and the patient, how can we manage actually to be amputated as early as well? Currently, the patient comes on daily basis as a day surgery, stay in the short stay, and finally, with the use of the erector spinae block, which is became now one of the very famous nerve blocks, the patient actually the next day could actually manage to go home. So I believe that although that we were not really applying the use of nerve blocks in the cardiac surgery in some of the centers, because it is not really very popular. However, currently the application of the other protocols, keeping even the nurses aware about the use of the BCA and the prescription of medication, the combination of the drugs that might really helps to reduce the need of opioids, might really helps to facilitate the patient recovery and wheel him all the way from the ITU all the way to the ward immediately. And if the patient definitely with surgery like the cardiac surgery, rather than staying for 2 weeks in the hospital, if you stayed like 2 or 4 days, definitely will be a very, very good achievement.
Yeah. Do you want to add anything, Dr. Medhat?
Yeah, I would like to explain something very important for everyone. When Henry Khalid started ERAS, I think I will ask Saad one time. I might in another week give a lecture about ERAS in general, because I think people should understand Henry Kellett is a very, I'm honored to be one of his close friends, and we go together to many places and we lecture in many countries all over the world. Henry Kellett, when he started ERAS, he asked himself a very simple question. He said, why if I have a car and this car, the tires worn off, I take the car, go to the mechanic, change the tire and drive it immediately and go out. In the same time, if I have somebody with a bad knee and he goes to the hospital to change the bad knee and put a new knee, he will stay in the hospital for 10 days or 1 week.
Mm-hmm.
This was the first question he asked himself to go to ERAS. He didn't go started ERAS, he started fast track surgery. We have to remember that. So he started to study the pathophysiology, what things in our physiology which makes the recovery better and what things delay recovery.
Mm-hmm.
And he started then to think about the stress response, and he found at that time that mainly the things which delay recovery are the stress response issues. And the things which which enhance recovery is to minimize the stress response. So that was the idea. And actually, Henry Kellett is a professor of colorectal surgery, and he's the one who started fast track surgery. And then the society said that the word fast track surgery give an impression that all his concern is speed. But no, let's call it enhanced recovery after surgery, because we are emphasizing that it's the quality which we are after, and this quality will lead to speed at the end. And he's a professor of colorectal surgery. He's the most famous doctor all over the world now, and they call him in the States the most famous anesthetist in the world, anesthesiologist in the world. Why? Because he thought about recovery. He thought what we should have been thinking, actually. So after that, it spreads in colorectal, and then it spreads everywhere. And in the UK, the task force and the consensus statement in 2012 was saying that ERAS protocol should be the normal, look at that, should be the normal in all patients undergoing major surgery.
Mm-hmm.
So the idea till 2012 was we apply ERAS for major surgery. When I started ERAS in the UK, when I was working in the UK long time, and then I came to the Gulf, and I found patient in recovery suffering from pain, from shivering, and I said, okay, the best way is to put this in a platform to change the practice of my colleagues who are still getting their patient out with hypothermia or shivering or pain. Okay, and then I said, ERAS is evidence-based, perioperative. So why only in major surgery? Ask yourself this question. If my son is coming for, I'm now a grandfather. My grandson is coming for adenoids or tonsillectomy. Do I want my son or my grandson to have shivering or to suffer from shivering or pain? No. So I started using it in my cesarean sections, because in the hospital I was working was a cesarean section, lots of cesarean sections. And actually I audited my work against my colleagues because they didn't do ERAS for cesarean section. I was doing ERAS, and I implemented every step of ERAS which is applicable to cesarean section, and I used it. And what happened? When they came, Henry Kellett and Ole Ongvist, the ERAS Society president, when they came to the Dubai in 2015, when we had the first Middle East conference, I showed them the results. And then we started ERAS in cesarean section. And because I was the one who started it, they put me in the task force, and we published 3 papers, which are the Bible for ERAS in the American Journal of Obs and Gynae. So the idea is that, and this is my mission for all of you, is to implement whatever element of ERAS applicable to your patient. That's it. Because you mentioned, Haytham, one thing, that when we send the patient to the ICU and we want to do that, and we are not sticking, you know, like the idea is not to do ERAS or not to. I am allowing my patient to drink and to drink hot tea and coffee and the juice and the water in the recovery room, not because of ERAS, it's because it's evidence-based. They will improve the outcome.
Yeah.
And this will lead to improvement. So ERAS is using the evidence-based. It's not, I'm not fighting for ERAS to implement ERAS, fighting for evidence-based medicine. Don't stick with the old rules that the patient should be in bed. The patient should go to the theater on a trolley. Why?
Yeah. Yeah.
I'm a patient coming to do shoulder operation. Why I go to the theater in trolley? Nobody knows. When the surgeons write kneel by mouse for 4 hours post-operative, why he's writing that? If you ask him, he will say, I was trained like this.
Yeah.
His senior told him 4 hours. Somebody else will write 2 hours. No reason, no evidence. It's just dogmas. So try to analyze every step you do and what is the best evidence, and do the best evidence, and you will achieve ERAS. That's it. Thank you.
Thank you very much.
Fantastic, Dr. Medhat.